We have the last talk, the last session of the day that's transitioning into more clinical aspects, and then we're going to do a quick wrap up. So in the interest of time, we're going to start with Jack, who's joining us from Norway. And Jack published a paper this year that generated a lot of discussion in our parent group because it was talking about an intervention with 2 adults. So there are very few papers out there that talk about CTD adults in general. And this was a very interesting topic for us. And second of all, it had some clinical implications too. So Jack, please take it away.
Thank you for your invitation. I'll try to share my screen here and find my presentation.
We can see your screen.
Yeah, fine. I'll just go to the start of my presentation then. You
Thanks
see
so
my
much for staying
presentation
up
now?
late. Yep, perfect.
Yeah, fine. I believe I was invited to the conference because of this article. As mentioned, we describe 2 adult patients we try to treat. And this was published in an article in February this year in the Molecular Genetics and Metabolism Reports. I'm a neurologist and I work in this department in Bergen, Norway. As you see, we have cars parked outside. In fact, we have 5, and we use them when we go and visit patients. So we do not only work in our offices. And both the patients we are mentioned here, we usually went out to the patient. Then I'll start with the first patient. He has an ID, and the level has not been classified, but I suppose it is around moderate. The cause of his ID was unknown when I first met him. He has some aggressive behavior, but otherwise he was well functioning until age 29. So then this was the time I first saw him because of these changes. He had mental changes, was more anxious and had self-injury, and his epilepsy was also worsened. I referred him to the neurologic department for evaluation. And there they said that this deterioration is probably caused by the unknown condition that has caused his ID. And they sent him to the genetician. So the genetician stated that this patient had a maternal half-brother and also a male cousin who had ID, and their mothers were sisters. So she suspected an X-bone syndrome. There was done an analysis in Netherlands and detected an SLC6A8 deficiency, which meant creatine transporter defect. So this was the explanation for all of them for the reason of their mental intellectual disability. Yeah, I suppose this disease is rather well known in this audience, so I'll just make it short. In this defect, the creatine doesn't get into the cells, and it is important for the energy balance in the cells. The effect is especially harmful to the central nervous system. And at this time, there was no established treatment for this disease. Then after a couple of years, the health of this patient had gotten worse. it was very challenging to give him the nutrition he needed, and he got a hospital bed at home. So the caregivers asked us, is there really nothing you can do for him? So I believe the correct answer was no, but well, I did a PubMed search, and I found this article by Mary Dunbar and others. It was the best treatment article at this time. So described some patients with this condition, and also results of treatment from different authors. And the recommendation was to give creatine, arginine, and glycine in combination. And the article showed some beneficial effect, but mostly in children. None of the male patients who had a clearly beneficial effect were over 9 years old. And then this article had a reference to an article about cyclocreatine treatment, which improved cognition in mice. But I found no articles about treating adults. So I discussed with Dr. Sigrun Hope, who is also watching tonight. She proposed to try treatment described in the article, but try cyclocreatine instead of creatine. Then we found on the internet a proprietary blend, which stated to contain cyclocreatine and some other ingredients, and we decided that they could give it a try. The manufacturer did not want to disclose the exact content of this blend. Cyclocreatine had been invented by Loomis Pharma in the USA, and at the time they were investigating whether this could be a suitable treatment for creatine transporter deficiency. We also sought advice and support from the last author of Dunbar's article, who was Clark van Karnebeek, who was in Canada at the time. The parents consented to the treatment trial. So I did the clinical examination before treatment, and the man was in a rather poor condition. It was difficult to perform a full clinical examination. He was able to walk, but he was unsteady and could hit the walls. It was very difficult to feed him because he didn't understand what was going on. So here we go. The doses of arginine and glycine were approximately like in Dunbar's article. So the first time I saw the patient after starting treatment, I was really disappointed because there were no beneficial effect and probably some side effects of the treatment and very bad balance. It's full of hematomas on his body. So we decided this couldn't go on like this. We had to remove some of the treatment, but we didn't have time to just take one and one away. So we took both glycine and arginine and continued with the proprietary blend. So 2 months later, there was an improvement. The patient had better stage on gait, both walking, eating, and speech had improved. And he said there are some phrases here on the bottom. They are translated from Norwegian. So this continued for some months, almost a year. But then it was difficult to get this proprietary blend, and the manufacturer stopped the sale. So we couldn't get it after February 16, and it was discontinued. During the next month, the patient's condition was deteriorated again. Then something surprising happened. I got a chance to be informed about an analysis of exactly the same proprietary blend as we has used. And the last point is the most surprising, because there was no circular creatine in this mixture. But anyway, it did have a beneficial effect on this patient. So then there must have been another ingredient that was efficient. And then betaine is the major ingredient, and creatinine is more like garbage. So we believe that betaine was the most probably constituent that gave the beneficial effect. Cyclocreatine was out of the question. And in addition, I was informed the year after that Lumos had safety problems with the cyclocreatine animal experiments, and at last, lately, 2019, they gave it up. So betaine is trimethylglycine and is used for treating homocystinuria, so it's a known drug. Some plants also contain betaine. It increases the methionine level, but in some cases this can cause cerebral edema. So we mentioned betaine before and start on treatment. So this was a treatment from March 17. We gradually increased the dose, and it was well tolerated. So the betaine dose was a little lower than the fraction he had when using the other treatment. After half a year, there was an improvement in his general condition, including feeding and walking. He had not reached his level he had before stopping the proprietary blend, but still it was a clear improvement. His methionine level was increased, but not near the levels causing brain edema. And he has continued to take betaine since then.
So Jack, quick note that we started a little bit late, but we'll have to wrap up in about 2 minutes.
Yes, okay. Patient number 2, half border of the first one, better functioning in until about 30 years old. Then he was losing function, needed more help, was very lacking energy, used very long times on meals. He had, he was underweight, kept his eyes almost closed when I saw him. He had moderate ID autistic disorder. And then June 17, he had increasing problems with weight loss. But at this time, his brother had used betaine for 3 months and had a beneficial effect. So we gave betaine to this brother too. And in addition, we arranged it so that he could get more support during the meals with caregivers and take time away from his job. Feeding was rapidly improved. After 4 months, he works 80%. Needs attention, otherwise he will forget to eat and drink. But he is with caregivers at inside, and so he appears to thrive better. So there we are, 2 young adult patients whose main problem was severe feeding difficulties, and now have stable condition and good quality of life. So how does betaine work? We have some hypotheses in our article, but it is difficult to say whether it directly influences creatine level or there is a more unspecific effect. I don't have time to go more into this now. So I'll just thank the patients and parents caregivers also helped us, and the co-authors, Søgrun Hoppe, Christian Watzelle, and Clara van Karnebeck. Also Torn Fiskerstrand, who diagnosed the patients, and she gave advice during the process, and also encouraged me to get the article published, but she died in 2019 and was not with us in the finishing. Thank you for your attention.
Thanks so much, Jack. We'll come back to the Q&A.
I'm the last presentation of the day. Thank you all so much for sticking with this. This has been an absolutely wonderful conference. I've learned so much from my scientific colleagues and from the family experience. I'd also like to thank Judy for presenting on the Vigilance study, which we were very happy to inherit from Lumos. We are excited that the study is now completely enrolled, and there will be an announcement going out this week, a letter to the ACD and other patient organizations with that announcement. So that does not mean the study is ending. It means that the patients who are enrolled will complete the 48 months of assessment. So we will continue to gather more data like the data that Judy just shared with everyone. So one of the really important aspects of drug development at Ultragenyx is to learn from the patients and the caregivers. And we are obviously learning a great deal from Vigilance, but we wanted to sort of round that out. We wanted to hear from more caregivers and also caregivers from other countries and so forth. So in order to do that, we embarked on a couple of different projects here. And these projects were mostly done by our wonderful core team, an outcomes assessment team at Ultragenyx, Ayla Evans, Tricia Sims, and Susan Blair, and by Kristen Voorhees, who many of you know as our patient advocacy person in charge of our neuro programs at Ultragenyx. So I'm really just presenting their terrific work. They are truly dynamic and very, very focused on getting the patient voice into our studies from the very beginning. All right, so we've kind of been through all this. The main takeaway point on this slide, I think, is that the broad manifestations of CTD overlap with other disorders, which can potentially contribute to misdiagnoses. And we have heard this over and over again from the caregivers that we have interviewed and heard from. So the objectives of these two measures, one being the advisory board and one being the online survey, were to gather information directly from caregivers of patients with CTD so that we could really understand what the patient and caregiver needs and concerns are. This is really important because sometimes as physicians or a company working on developing a treatment, we tend to think we know everything. We've read a lot of articles, we've talked to doctors, we've talked to scientists, but we really know that it's very, very important to find out what exactly the patient and caregiver are dealing with on a daily basis. So we really go out of our way to try to learn that. And we would like to thank the ACD for helping connect us with some of the patients that participated in both the advisory board and the survey, because we really appreciate being able to draw from these different experiences. We wanted to know about the diagnostic path, what kinds of healthcare providers patients saw along the way, what were the not only the symptoms that we keep listing over and over on our slides, but what are the impact of those symptoms on the day-to-day life of the patient. We wanted to know the experience with various types of treatment, the impression of the caregiver as far as whether those treatments were effective or not, how they made decisions about what treatments to try, what support services they're currently using, and their experiences within the healthcare system and with healthcare teams. We also wanted to know something about the challenges, concerns, aspirations, and unmet needs from the point of view of the caregiver. So we recruited caregivers for the advisory board through advocacy networks such as ACD and social media from the United States and other English-speaking countries. We wanted to be able to converse directly with the caregivers so we wanted them to be comfortable speaking English because that's the language of our team, with the acknowledgement that this does kind of limit the information we're able to get. The caregivers participated in a virtual advisory board through a series of teleconferences and online discussions. And then we also had the ability for them to answer additional questions in an online, secure online platform after we had our discussion with them. And the live discussions were conducted via a GoToMeeting secure HIPAA compliant video conference platform and within 3's secure platform. And this was a very, very helpful exercise. And we also were pleased that the caregivers were able to speak to one another because some of them found that extremely valuable. This is a visual that I particularly like because it just kind of shows easily the open circles are the age at which symptoms were first noticed. The half colored in circles are the age at CTD diagnosis. And then the solid circles are current age of the patient. So you can see that we talked to people in the European Union and the UK, as well as North America and Australia. So it gave us a little bit broader perspective than we sometimes get. And you can also see the big, often really long gaps between symptoms being noticed and a diagnosis being given, which is clearly a problem. There was a prolonged path to diagnosis due to lack, again, the lack of disease-specific signs and symptoms. In the child's first few months, caregivers often reported things like breath holding, projectile vomiting, general lack of engagement. And then there were often a lot of other diagnoses given before the CTD diagnosis, including failure to thrive, developmental delay, autism, etc. And then sometimes comparisons to other babies at the same age, like if the mother had a child who was neurotypic previously, and then they would say, gee, my child isn't necessarily meeting the milestones. One parent who was not in that situation is quoted here. This was our first child, so we didn't have any comparisons. After our second child, we looked back and there were earlier signs we just missed. And I think this is probably a common occurrence. So there was an average in this particular group of 6.8 years from symptom onset to diagnosis. 6.8 years, that's just unacceptable. And the range was from 2 to 19 years. Most families noticed pediatricians may have been dismissive of parental concerns, adding time and frustration of the diagnosis. 8 children were diagnosed by a geneticist, but the genetic testing may have been conducted only after several referrals. So again, getting the correct genetic test for CTD was often a challenge, even when they were seeing a geneticist. Greater than 50% of the participants reported inadequate resources available at the time of diagnosis. And here's a quote from one parent. I had 4 children and was told unless I was going to have more, genetic testing didn't matter. What does it matter what he has? They asked me. So, which is, I'm appalled on behalf of all physicians for that kind of insensitivity. So post-diagnosis, the symptoms tended to evolve and caregivers noticed an age-based pattern. The younger children were most impacted by a general failure to thrive, delayed milestones, disinterest in surroundings, sensory sort of hypersensitivities, and then the older children and immediate family members were most impacted by behavioral issues. So again, here we are looking at not only the symptom, but the consequence of the symptom, which is that there were often disruptive behaviors, which included aggression towards others, potential for self-injury, and loud vocalizations, and some difficulty managing, as this parent expressed here. We parents are getting older and weaker, they're getting bigger and stronger. As he gets more capable, it's harder for us to manage him. This is another thing that we heard. Treatment experience and support services. Most caregivers learned of creatine supplementation from a physician. 7 of the patients were currently using creatine, 3 never used creatine. 5 of 9 patients were being treated for severe behavioral issues. Speech, occupational, physical therapy were providing noticeable benefit to most patients. And I think this is really important. assuming that, hopefully everybody can have the resources to get those therapies for all the patients. The importance of augmentative and alternative communication devices were noted, things like iPads and other devices. The two interventions that the parents thought would be the most difficult to go without would be speech therapy and anti-epileptics. So now this is the other thing we did, was this caregiver online survey. And again, trying to spread out our catchment area to get a wider variety of input from caregivers. So I'm not going to go through this because I'm sure I'm running out of time, but we use non-clinical recruitment sites, advocacy networks, including ACD again. We distributed IRB approved recruitment flyers to potentially eligible responders. They were screened on the phone and then got a link to a SurveyMonkey survey, which began with the informed consent form. So again, all of our studies we do in a HIPAA compliant manner and make sure that we get appropriate consent from the participants. The survey included questions about diagnosis, family history, CTD management, symptoms, impacts of disease, and then the data was descriptively analyzed, and open-ended responses were coded with qualitative software. So in the survey, 37 caregivers provided online data for 40 unique children, 37 males and 3 females. They reported in this case, with this different group, it took 4.3 years on average to receive a CTD diagnosis, which is better than 6.8, but not acceptable. On average, children were 1.4 years old when they began displaying symptoms, and 5.7 years old at diagnosis. The most frequently reported initial symptoms included gross motor delay, speech delay or impairments, global developmental delay. And the caregivers reported that their child saw on average 5.7 specialists before receiving a CTD diagnosis. So we really need to be better. Some of the diagnoses that were given, and this is a little bit unfair because some of these things are under the umbrella of CTD. So it's not like they were misdiagnosed, but they're just not diagnosed with a specific condition. And that included global developmental delay in 81.5% of patients, hypotonia, epilepsy, sensory processing disorder, gastrointestinal conditions, autism spectrum symptoms, apraxia, and cerebral palsy, which is very nonspecific. The specialists seen for the ongoing medical needs for CTD included speech therapy, occupational therapy, physical therapy, and the board certified behavioral analyst that Judy mentioned previously for treating autism spectrum type symptoms, and then other specialists as well. By the way, this was shared with ACD and it's, I believe, in its poster form, so you can go back and look at their website to get more information about this. Children with CTD and caregivers were most impacted by issues with speech, nonverbal communication, behavioral challenges, cognitive issues, and seizures. And you can see that even though seizures, as Judy presented earlier, happen in a significant number of patients, I believe the final percentage in the Vigilance study was about 68%. You can see that this was not the most impactful symptom for most of these caregivers. The language, the communication, and other things were more impactful than that. So I think this is why it's so important to go to the caregivers and really ask what are the most important symptoms and most impactful symptoms. This is another significant number here, that the total number of hospitalizations, and 17 of the responders reported 5 or more hospitalizations in their families and with their family member, and that is also a really big number, and that every one of those represents a very stressful and fraught experience for those families, especially today with COVID and everything. The reasons for these ER visits and hospitalizations, seizure was the most common, but also things like vomiting, broken bones, needed an MRI, various other symptoms. So the conclusions were consistent across the advisory board and survey, and included the fact that there's a broad spectrum of symptom presentation. There are challenges to receiving a diagnosis of CTD, especially in a timely manner. The impact of the symptoms continue over time. These findings provide preliminary insight into the burden of CTD and enhance the need for better diagnostic tools, enhanced support for families, especially of newly diagnosed patients, and effective management and treatment. The study was funded by Ultragenyx. All of us are employees and stockholders of Ultragenyx, and we had medical writing support. And again, I'd like to acknowledge our team for putting together this really, I think, important piece of information, and especially the caregivers and the patients who participated. We really appreciate this information.
Thanks so much, Melanie. This was a great presentation, and thanks for sharing, both you and Judy and Jack, all of these results. It's nice to see when we have consistency across the data that we're seeing. And I did want to emphasize that the ACD has a Corporate Alliance for Research program that Ultragenyx is part of, and we've loved the feedback that we're getting from our care partners and how we can make sure that the data we're collecting from studies like the Creatineinfo patient registry is meaningful across the board for clinical trials potentially down the line. So with that, we have a couple of minutes for questions. So Celeste is our Director of Education, and Sylvia Stockler, you've already met before. She has a long research in both CTD and GAMT and clinical outcomes. So they're going to be our moderators for the session. We can try to go for, so technically we have until 1:30, and I have the last talk of the session. So we can be a little bit flexible, especially if our audience is flexible. So Celeste, 10-15 minutes for questions would be great.
All right, guys, as before, if we could keep the responses short if possible. We'll start with Judy. Let's see. How are the extended measures that are completed at the NIH incorporated into the data from the Vigilance study?
Great question. So all the families who were invited to participate are invited to also go to the NIH. So we have all the sites across the US and Canada, but then you also are invited to go at least once to the NIH and get a spinal tap and MRS and other measures. And so it's only a subset of the kids that get that. And so what we'll be doing is we'll be incorporating those into our first sort of manuscript about big picture, but it really is a subset. So we have to be a little cautious about what we.
And when do you anticipate that first?
Yeah, so we're in the process of writing it now, and Ultragenyx has been super helpful with that. So so hopefully it'll be submitted in the next couple of months. That would be the dream. So hopefully soon.
Sylvia, do you want to ask a question?
Yeah, there were a couple of questions for Jack regarding the Betahine treatment. That, people wanted to hear more about theories, how the Betahine could have worked. And the other question was whether any adverse events, or could one maybe avoid adverse events by a diet that is rich in beets? So.
I can take the last question first. We didn't see any adverse effects of a Betahine. We were especially interested to see whether there was an increase in methionine, and we know that cerebral edema may be a dangerous complication, but there were no signs of that in any of them. There was a question if you could take Betahine in diet instead. I found that content of Betahine is 100 to 300 milligrams per 100 grams in beets. And if we say 200 milligram, then we have to multiply with 50 to get the dose that the first patient got. And then that makes 5 kilograms of beets per day. So I suppose that would be a bit difficult for most people to digest regularly.
Yeah, just because of the side effects, as you said, the brain edema is a side effect of betaine. As far as I know from using the betaine for treatment of homocystinuria, we are measuring the methionine levels because it's obviously the hypermethionemia that causes the brain edema. Did you also measure methionine, plasma methionine levels?
Yes, we did. There was a rise of the methionine in both patients, but not so high as that there was a real risk of cerebral edema, and there are no symptoms that could be connected to that.
Okay, we have a question for Melanie. Thanks for the great presentation about CTD. When will you and Ultragenyx be giving an update about the ongoing research for CTD, about the IND filing? When will the community be able to get an update on that?
Well, this is the $64,000 question. And we provided an update in May, which is on the ACD website, of course, and we'll continue to provide updates as we move along. I think it's been really well demonstrated in the last 2 days that preclinical work is dynamic. There are a lot of twists and turns. Some things work the way you think they're going to, some things don't. Sometimes you are moving along one path and you find a better path, so you go there. And so it's a very dynamic process. And so it's, you know, we would love to say, oh, here's a date, here's when we're starting with an interventional study, but we're just not ready to do that. We will certainly provide information to the community as soon as we have that information, but we're just not quite there yet. As you can see, we're doing so much work to understand this disorder, to learn about the patients and the families. This is how we build our programs at Ultragenyx, but it takes time and it takes patience. And I know it's frustrating. It's frustrating for us too.
So just a quick follow-up to that, would you anticipate that, because in previous communication, it's been stated that you guys were hoping to file an IND in 2021. We're, you know, getting towards the end of 2021. If that were to change to 2022 or whatnot, would you anticipate that being in an update to let the community know, hey, it's been, you know, pushed due to unforeseen circumstances or whatever?
You know, that's a really good question, and that's sort of more of a Ultragenyx as a whole question. So I'm not really prepared to answer that. I will just let you know that we have every intention of being as transparent as we can, and we'll update you as soon as we can do that.
Okay, thank you so much. Sylvia?
Yeah, so before I go to the next question, I just wanted to follow up on the previous question about the mechanisms, how the betaine might have worked. And Jack, you gave a couple of explanations in your paper, and also you mentioned them in your presentation, which are mostly metabolic, looking at GABA, or, you know, providing adenosine as a substrate for creatine synthesis in the brain. So if you remember Peter Axario talk, he tested also betaine as a potential candidate to chaperone activity, because betaine is known to be a potential chaperone in other conditions and for other genes, particularly in homocystinuria. But what he showed is that in the particular mutation that your patients had, there was no effect, which doesn't mean that it wouldn't work for other mutations. So this is just another addition to that question. But there was another question by a mother of a patient with creatine transporter deficiency who is concerned about creatine transporter deficiency children to be at higher risk for a severe form of the disease caused by COVID infection, or whether they are more at risk for long COVID, particularly also because yesterday they heard that there is a potential QTC prolongation. Is there anybody who could answer that question?
I'll take a very preliminary pass. So behaviorally, a lot of families have been, behaviorally, it's important for us to try to teach our kids how to wear masks, right? So just because your child has autism or an intellectual disability, if you can't really reliably wear a mask, that might prevent you from participating in a lot of things. So you want to build that in. And if you're working with an ABA therapist, they can help you with that. As far as the vaccine, there are some known allergic reactions that people have. And so you'd want to be sure that you're staying away from those. But otherwise, I think it would be just important to talk to your physician about your particular child's profile. And for most people, there's not really any good reason not to take the vaccine. Most of our kids are not old enough just yet anyway. So maybe there'll be some new information when those trials are published, but I wouldn't assume that it's unsafe. I would assume that the vaccine is probably safer than getting COVID.
Okay. Judy, can you hypothesize why creatine deficiency gives rise to GI-related symptoms?
Sure, I'm a psychologist, and now I'm making my second sort of fake attempt at being a doctor, so sure. So, you know, again, I'm a psychologist, but I think there seem to be it could be a motility issue. That could be one thing. We know a lot of kids who really had struggled with formula and breastfeeding and went through everything, and they were just throwing up all the time, even like sensitive formulas. And then once they get to solid food, they don't throw up as much. So that seems more like a muscle issue than a chemical or nutrient one. So that would be one guess. We know there are other motor problems, but beyond that, that's probably all I can safely guess.
Can I add
Melanie's an actual doctor.
So I come from the world of Parkinson's disease, and there are a lot of GI symptoms in Parkinson's disease, and we know that there is a nervous system in the gut. In fact, in Parkinson's disease, the gut gets Lewy body pathology probably before the brain does. So I wonder if there might be something going on with the neural system of the gut, but of course, the gut also has muscle, as Judy points out. So it's probably some interaction between those two things. And that's my opinion as an adult movement disorders neurologist. So that's my disclaimer.
And this one is actually for both of you. Thanks for your insightful studies. Melanie's comment about aging CTD patients getting harder to manage was very interesting. What's the age distribution look like for the caregiver surveys and vigilance studies? Did it skew to young patients? Could you expand on experience, seizures, behavior, survival of CTD patients into adulthood based on your data or clinical experience?
Well, I can start, and then Judy, you can fill in. So I would say we had a pretty good representation of patients across the age group in Vigilant and in the surveys, because our team worked really, really hard to make that the case, because we really wanted to learn from all of those areas. I will say that, you know, this is a relatively young disease. As we pointed out yesterday, it's a 20-year-old disease. And so we don't know a lot about what happens to adult patients, because a lot of them probably were just never diagnosed and are out in the community or in a care home or some other situation. So we don't know. And so we've just launched our patient find efforts to officially start really looking for patients. And hopefully we'll be able to figure out some algorithms or something to learn more about the adult patients with this condition, because we know they're out there. A lot of them just haven't been diagnosed. And that's why we really appreciate the efforts of the ACD to sort of help spread the word about this, get their registry going and so forth. I'd say we don't know. We're still learning. That's why we're doing everything we're doing. So, Judy, you wanna
Absolutely. And
add to that?
there's definitely thought that it's definitely underdiagnosed. So there's probably several adults out there. This is for Jack. This parent went through your publication and the description of CTD adults conditions worsening. It's scary for us as parents. Do you know if there's other literature with the same observations or? You're muted, Jack.
The observation of deterioration in adult age. I have not found other articles that show deterioration of the general condition in adult age. But we found it in 2 patients then. So it can of course be discussed why these people worse around age 30. There was something about lack of energy in both of them, and also the nutrition was insufficient. So when they got a bit more energy, they were able to eat better also. So but I haven't found any other articles describing this worsening of. And anyway, I hope if other patients experience the same, I hope they can have some treatment, like for example, Creatinine, to avoid serious consequences.
Yeah, I think there's one article that was one case report that was published many years ago. I'm not able to cite it now, where they report about an adult patient with mostly GI symptoms, and also have the impression that that patient had deteriorated over the time, and put out the question whether it might be a very slowly progressive condition with loss of IQ points over the years. And that was actually a question that I had asked to Judy in the chat. What was the age of your patients, of your participants, when you did the first IQ test? So were it more like older patients who might already have a lower IQ, or was it kind of distributed across all the ages?
Yeah, that's a great question. So we did it at the first baseline. So most of our participants at baseline were either 0 to 6 or 6 to 12, and then we had a few kids that were older. Now, it is true that from a score standpoint, as you get older, your scores are going to look lower, but it's not really that you're regressing or losing skills. It's more that when you're very young, there is just less is expected of you. So there's not a big opportunity for you to look impaired relative to other babies, your peer babies. So if you're under the age of 2, you're just not going to score that impaired because not much is expected yet. But then starting at about 2 or 3, the kids without CTD are growing like this, and the kids with CTD are growing, but they're growing much slower. So the gap starts to widen, and that can make it look like you're losing, but you're not actually losing. It's that you're just progressing at a much slower rate.
So Judy, thanks for that explanation. I think neurodegeneration is a concern, and long-term neurodegeneration. And is it fair to say that we actually don't have the data from like older adults to point out if there is neurodegeneration? We had some inklings like Jack's paper and Ton de Grasse paper from early on that neurodegeneration may be a concern. But
yeah, I think it's probably safer to say we don't know. But also, like there are some anecdotal, at least, incidents of young adults learning, having a language burst after puberty, where they start speaking in phrases or sentences when they weren't before. And also that after puberty, when their hormones stop, going crazy, that their mood gets better and they're happier, and they're just able to participate more and stuff like that. So it might be that things are the course is just really different. It could be that some things are delayed, maybe neurodegeneration happens when we're older, but I think it's safe to say we don't have enough data of all of that.
We need more research. I think this is the theme for the past 2 days. So thanks everyone. I think we had a wonderful conversation, and thanks Melanie and Judy and Jack for sharing all this research, and Sylvia and Celeste for being fabulous moderators. I think this is officially how we're ending on a high and on a wonderful discussion, the talk portion of the day. And we can take a very short break, but my goal was to kind of do a big picture recap. So unless I hear any objections, I'm gonna give it 2 minutes and set up my slides here, so that we can do like a wrap up of the conference. And in the chat, folks, feel free to comment, feel free to enter, what you think about the conference. We're making these conferences happen because we strongly believe that community is the way that we're going to move these diseases forward.